We know that BRAF and MEK combined inhibition clearly gives a very good response rate initially, but is troubled by the development of acquired resistance in the vast majority of patients. There is perhaps a subset of patients that do not develop resistance and can remain with disease control for prolonged periods of time, but the vast majority of patients do develop resistance. So we need to overcome that problem. So what is intriguing is that many of the acquired genomic events that occur in the tumours when they become resistant reactivate signalling downstream of BRAF and MEK of the MAP kinase or ERK-signaling pathway. Now what we've been very interested in is that a part of that pathway is an old oncogene known about for a long time, a key nodal point in controlling cell proliferation, which is cyclin-dependent kinase 4. So this is the kinase that regulates G1 to S progression. It is activated in the vast majority of cancers. 80 to 90% of human cancers have genomic events that activate the kinase activity of CDK4 to dysregulate the cell cycle. Now in melanoma, this is a very important nodal point of regulation of the cell cycle in a melanoma because we see very frequent events that activate cyclin-dependent kinase 4, loss of its inhibitor P16 or CDKN2A, or amplification of activating proteins like cyclin D1 or even amplification of CDK4 itself. So it occurs very commonly. And interestingly, CDK4 activity comes up when patients become resistant to targeting of the BRAF pathway. So we have postulated that targeting CDK4 in combination with BRAF and MEK inhibition is going to be a useful strategy to overcome resistance. And what we've found using the small molecule inhibitor palbociclib, a selective inhibitor of cyclin-dependent kinase 4 and also cyclin-dependent kinase 6, that combining that with BRAF inhibitor, we can prevent the emergence of resistance in preclinical models, both in vivo and in vitro. So we think this is very promising, and some clinical trials have been commenced, and we are planning to commence a clinical trial of a triplet with BRAF, MEK and CDK4, which we hypothesize will prevent the emergence of resistance. But I think very importantly now in oncology, whenever you're postulating a new strategy, you should think about resistance from the get-go. Even before you've dosed the first patient, you should be studying mechanisms of resistance. So we're doing that in the laboratory. And interestingly, we find that another cyclin-dependent kinase, CDK2, can mediate resistance to CDK4. So we have various strategies now we're looking at to inhibit CDK2 to overcome resistance to CDK4. So going forward, first step is to see whether really the addition of a CDK4 inhibitor to BRAF and MEK will extend disease control, prevent the emergence of resistance. But even beyond that, we're already thinking about are there strategies that could salvage even patients that become resistant to that triplet. So it's an interesting era in oncology now, where we really are starting to understand at the molecular level the basis of response and resistance to therapies, and we can plan rational development strategies for these targets going forward. I think the future is bright for melanoma patients. Now we have tools both in immuno-oncology and targeted therapy that we can really continue to push the barriers and shoot for long-term disease control for patients with metastatic melanoma.